So, first of all, I welcome Dr. TITUS to be here with us to share his knowledge on bone tumor. This is actually a fourth webinar on bone tumor board. Thanks to Kushik for arranging this nice arrangement. Because with this webinar, we are having at least 10 times the 10 times participants as we have in the physical form. So, and also Dr. GIRI is here. He will share his presentation. So we enjoy all these cases and we have some new knowledge. So with this, few words I conclude and let us start the program.
Thank you, sir. So it's a great privilege to have Professor Dr. VTK TITUS. He is the head of the Department of Musculoskeletal Oncology, Christian Medical College, VELLORE, Tamil Nadu. So welcome, sir. So we'll request you to start your lecture, which is on new trends in surgical management of EWING'S sarcoma. Over to you, sir.
So I must thank you all the organizers for having invited me for this talk. And let me try and share. Shall I share screen again? So is the screen come up for? Yeah. Okay,
yes,
right.
yes, sir.
So
put it in slideshow mode, sir.
Yeah.
Slideshow.
Okay, right.
Okay.
And
okay, perfect.
So we'll start on EWING'S sarcoma. I'm talking the surgical advances. I'll go quickly across the introduction, epidemiology, clinical presentation, radiology, pathology, prognosis, and then come down to the surgical advances. James Ewing had described this way back in the end of the 19th century. He himself died of bladder cancer, and he started the American Cancer Society. He had worked in Sloan Kettering Memorial Institute, which is both Sonia Gandhi had got operated there, and our ex-finance minister also, Arun Jaitley, had got operated there. It was identified by James Ewing in 1921. It is found out that it was different from osteogenic sarcoma, which was an earlier one, and the locations were a little different. Some results claim to have about 83% 5-year survival rates, but some people also claim quite low. We were all taught when we were junior that the Stanford Care regime, which is only radiation, it was what taught to us as students, that you don't operate these, you don't give chemo. The thing changed later and the chemo came in, and now surgery has become the mainstay. By 1969, adjuvant chemo was. What was happening earlier with the radiation was the patients were never living long enough for for them to realize whether the radiation is working out. So what happens, it's very radio sensitive, it melts very early, but soon after that, if you give chemo and other things and it will come back, so pure radiation. But that was the standard regime in those days. It has really changed from radiation and then radiation plus chemo, and now surgery is the mainstay, except in areas like pelvis and all that, where you have to wonder whether it is possible or not. The incidence is about 0.6 per million. Males are more. Most of them are in the second decade of life. Most people take it as 10 to 25 as the commonest. It's supposed to be rarer in blacks and Asians. And we do see a little more of osteosarcoma here, but from what I am seeing, it is definitely lesser than osteo, but it's quite common here. And considering our country's population, there is a huge number of this one, and for all the youngsters who are listening, kindly at least diagnose it and do an early biopsy or something, which is thing. We're having a lot more of things coming missed because as all the seniors who are partaking will remember, in those days we didn't have specialists of tumor or arthroplasty or anything that we were all doing everything. But now everyone sort of tries to push away a tumor away from them. Like most of the malignant tumors, the pain is the most common. 90% of them, swelling is there. Fever is a little more common than in osteosarcoma. Pathological fracture is less common. And there are more constitutional symptoms like weight loss and malaise. Now, The areas which are involved are a little different from osteosarcoma. Osteosarcoma is mainly which is the commonest primary malignant bone tumor. It's in the femur and the tibia. So here also, though the femur and the tibia has the highest, 20% is in the femur and tibia is 10%, but there's a lot more of pelvis. If you can see 26% in the pelvis, sometimes more in the chest, and other flatter bones also. As usual, some of them are diagnosed with metastasis and sometimes they're diagnosed with bone metastasis also. Cell of origin is unknown. Previously it was a diagnosis of exclusion, but now it's obviously and there is some reciprocal translocation in that. There is a pathology slide, very small round dark staining cells. The malignant peripheral nerve sheath tumor for the pathologist, these are the other things, alveolar, soft part segment, lymphoma. These are the other differential for the pathologist. For a clinician, it's only the osteosarcoma. There is a local warmth and inflammation, which is what leads to the main misdiagnosis of osteomyelitis. And I think we are seeing a little more of this misdiagnosis because it quite mimics an infection quite a lot. Pleural effusions is a rare one. Neurological infection is a rare one. Again, ESR and leukocytosis will be there, which again quite often is for a junior orthopedic surgeon who has not treated much. So one of the main things to remember is whenever you look at an infection, just always wonder, is it an EWING'S, especially if the pain is very severe and all that. Radiology is this thing. It's not very classical, though the classical teaching is there. We are looking at site, size, effects of bone. PET scan is done these days. We don't tend to do it very much, and you are looking for this. And the MRI, we are really looking whether vascular involvement there, and for surgery, it helps us on that. Though the classical radiology one is the onion peel, which is there on the right side, bone laying down, and the classical site is diaphyseal. We are seeing a very good number of metaphyseal also. It's really long diaphyseal and going on to the metaphyseal areas also. Now, if you look at the X-ray on the left, then it is definitely that periosteal reaction and all that can easily mislead somebody into thinking that it is. Of course, the X-ray on the right probably will not mislead somebody, but always this high index of suspicion should be in the mind when you are looking at any infection, that whether it's an EWING'S sarcoma, especially areas like ribs and all that is quite common to miss that. That's another X-ray. You can see the amount of onion peel really depends on how much of calcium has been laid down on this. That's another X-ray of an EWING'S sarcoma, but you can see it is coming into the diaphyseal. But there's there in the metaphyseal also. Again, this is coming from those. We've seen quite a few of these, which are the same. Sometimes we see mid-diaphyseal regions, but they are very classical. According to the pathologists, we ask them repeatedly, and they say, no, this is EWING'S sarcoma. No, it is in the metaphyseal. Something like this, we can again mislead person because there is so much of bone laying down. So you're looking at a very little periosteal reaction on the top left, and of course, a soft tissue. Clinically, there's a much larger this thing. And again, this should not be diagnosed by X-ray alone. And these days, I think we are doing a lot of this. We are also started telemedicine and all that, and some of us are a little hesitant of this because if you see this patient, there will be a huge swelling, and then only an infection or a tumor is to be thought about. So these are something which can mislead us, especially in this corona. Now the rib, you will hardly see anything on the X-ray. And I remember in 1987, I was assisting somebody, and we cut the rib open, and it looked like pus. And my senior was nearly not sending a biopsy. And I was saying, no, just let's send a biopsy, and it came as EWING'S sarcoma. So that is the rib is again because X-rays are quite misleading in these. Now, genotyping is being done in these things. There is 1122 translocation. I'll come down to genotyping a little later when this thing. It is mainly to this thing that we have reached with the chemotherapy and with the surgery, we have reached a certain amount of improvement in prognosis. And I think the future developments are going to come in the gene, and whereas you pick up the poor responders and then you give them more chemo or follow up the chest X-ray a little more carefully and all that. The surgical developments have happened. Now we are just sort of getting a better function with surgery. The surgical developments are not really improving the prognosis very much in the West also in the last 15, 20 years. They have not managed to improve the 5-year survival rate very much. And there's a lot of research on gene, and unfortunately in the last 10 to 15 years, there doesn't seem, none of these have given management-wise a letter. Obviously, we'll get some people from India who will go to US and probably will do some really earth-shaking things. Now, pathology-wise, it's gross, a soft and tan gray tissue. That's microscopically the rest of our thing. There may be osteoid or chondroid also, and there is some investigations. Clinical examination is definitely the most important thing, and your highest index of suspicion, if you are thinking of infection, that always keep in the back of the mind, is it an EWING'S sarcoma? A chest X-ray and HRCT, the HRCT is only after you get the diagnosis by a biopsy or all. You can plan it at the start also. Now, biopsy. This is our usual discussion in all our IM sources as to who should do the biopsy and this thing. Now, first I'll finish off the less controversial thing, the needle biopsy. We all prefer to do a needle biopsy. There are a lot of advantages in doing a needle biopsy to open biopsy, unless your pathologist is very against it to this thing. The problem with the needle biopsy is you get very small amounts of tissue, and so they should be able to. But there are a lot of advantages. If we presume that the tissue has not been spilled, whereas when you do an open biopsy, you spill the tissue. And so that is the other thing is wherever you get little necrotic areas, degenerative areas, that when you do an open biopsy, you get that. Obviously bleeding is less. So the other discussion of a curopsy has come in. It's quite popular in Bombay and some other parts. We all prefer a biopsy. And usually if you have a regular pathologist, then we decide whether we do a needle or an open biopsy. Obviously the pathologist will like this. As far as who should do the biopsy, I think there are so few of us pure tumor surgeons that a majority of these will be biopsied and treated. And I'm quite unhappy that now more and more youngsters are saying as soon as you see a tumor, refer it off, because we have a large country with so much. The only thing about doing if you're doing an open biopsy or a needle biopsy, as to it should be through the tract of the final surgery incision. So, like in the distal femur, usually we go anteromedial, and so that is probably the route to be used. It is probably not possible for every biopsy to be done by a tumor surgeon. Bone scan is part of the investigations to be done, which is to see that there is no bone scan metastasis. MRI is probably the mainstay of our investigation. It is to see the skips, is to see the intramedullary spread, the vascular involvement, and planning what surgery. PET scan is definitely useful to see whether there is mets at diagnosis. That's not it's still a costly investment, and you got to see for other sites, clinical examination or other sites. PET scan, as I said earlier, is just mainly a screening test. And later on, we can also see the post-chemo effects of that to assess how much it is affected. Now, of course, if you're thinking of a recurrence after you have done surgery and had chemo and all that, then again, a PET scan is very useful. Osteomyelitis and the differentials in pathology is the first thing. And as I said, the lymphoma, the osteogenic sarcoma also can be sometimes. So used to look like granuloma is malignant fibrous histiocytoma and metastatic neuroblastoma. These are all for the pathologist to make out on that. For the clinician, what I put in yellow, the osteomyelitis or the infection is really the one that is. Quite often people give some antibiotics and with them painkillers, and then the patient loses about 2 to 3 months in that. That is the only thing that always keep, in any infection, keep in mind is it an EWING'S or not. Now, chemo, I will not go much into this. In our institution, we keep chemo pre-op only for 2 tumors. One is EWING'S, one is osteo. In all the others, we operate first. So we give about 3 courses, vincristine, dactynomycin, and After that, ifosfamide we give sometimes, etoposide we give sometimes. That's what our chemotherapy team. Sometimes we give more. Sometimes we give up to 7 or 8 preoperative. It takes a long time to wait. We are waiting for surgery. Post-op courses depends on tumor necrosis. So when the tumor is removed by surgery, you give it to the pathologist and you must mention to them that the patient has had so many courses. So they are supposed to sample different areas, see what percentage is necrosed, and this is very crucial for the prognosis and for deciding how many more chemos do you need. Do you need to add some more chemo, etc. Now, recently there are quite a few reports. I'm just quoting one from the Chinese literature published in Clinical Orthopedics, saying, is pre-op chemo necessary? This was just a study on pelvis, and they found, because 68 and 67, they didn't find much difference in prognosis by this. And the other thing, what happens between in our multidisciplinary tumor board meeting is that low grade or intermediate grade, we again decide whether we need to give chemo or not. Usually EWING'S needs pre-op chemo. It's a high grade. Pre-op RT, I've just mentioned at the bottom. It leads to a lot of surgical complications, wound complications. And so I personally do not want a pre-op RT because anyway, surgical complications are quite a few. And so pre-op RT is, in post-op RT, I am very much for, especially if the margins are either positive or very close. Sometimes we have a new terminology that we use called planned positive, especially in the pelvis, where we expect that near the artery, it is, we tell the patient that the best solution is an amputation, but especially in the pelvis and all, sometimes an amputation is very disabling. So you may want to do a planned positive, but for a very small thing, and give some sort of RT, either the conventional RT or brachytherapy or something. Now we'll come down to surgery. Radiation, as I said, pre-op. There is also two other things which I won't touch upon. That is the soft tissue EWING'S that we treat like a soft tissue sarcoma. So we don't give pre-op, and the surgery is the first surgery is the best surgery, and it's best that we should aim not to get any local recurrences in that. Tumor necrosis, this thing, a factor which I said earlier. Anything less than 90% is poor prognosis. Anything less than 50% is already a more prognosis. You have to decide whether to do this. Local recurrence, when you do a marginal section, a clear margin is best for EWING'S sarcoma. For the limb ones, it's not the histological response, but the marginal resection, which is in central tumor, it does not make much of a difference. But still, we must aim to get at least a marginal resection, if not a wide excision. These days, it is the era of limb salvage surgery, so we are not able to amputate people. Actually, what is now the standard saying for the last 20 years is that limb salvage surgery is a standard of care. So amputation is what is not a very standard care. Unfortunately, in our country, many patients come so late, and so we still have to do a lot of amputations in our. Staging and prognosis is there. You must see that there is no metastasis, bone marrow aspirate. Some other chemotherapists wish to have that, and makes a difference. My chemotherapy is not much concerned with that. Biopsy is the over. So you divide them according to any king staging into low grade extracompartmental and high grade extracompartmental and low grade intracompartmental. Metastasis in our country, we rarely tend to operate. The tumor size is of prognosis makes a lot of difference. Response to chemotherapy, metastasis, that diagnosis. Genetic markers are not yet of a great influence, but we are working on that, and we are hoping that it will. Age of the patient, the younger the patient, the poorer the prognosis. Location, central location is not very good. The more peripheral it is, the better. Most of them are luckily distal femur and proximal. Now, allografts I'll come to a little later, but allografts are another obvious thing other than our usual radar processes. Radiotherapy, just saying, small tumors, if you can give pre-op radiotherapy. I rarely do small tumors, so post-op, in my practice, I nearly always ask for a post-op radiation. Pure radiotherapy is if it's inaccessible tumor, inoperable tumor, very high-grade tumors, we sit down in our multidisciplinary tumor board meeting and decide on that. It is necessary to have this tumor board meeting pre-operatively and post-operatively. These days we are doing it on Zoom. It is not that good. I generally go and sit with the chemotherapist and the pathologist and the radiologist are on the Zoom. But it is always necessary to have something on that. Large volume tumors also we give radiotherapy because they are also happening. And obviously if it's a positive margin, we give it. Now, I will give some examples. Right? So this is one classical diaphyseal one. It's a humerus one with a large soft tissue. You can look at it and make out that the artery must be involved. The artery was involved. This is at surgery. That is the radial nerve. We have dissected out this thing. That is the musculoskeletal nerve. The end branches of it is quite a large tumor on that. There was a path fracture on that already. That is a whole tumor specimen that we have removed with this, and we have put a total humeral process. This is an Indian one, and the one that I used to use. This thing, you can see the radial nerve is now completely gone medial to the prosthesis. So that anyway, it is quite lax. In the humerus, you don't have to look for very good exact length because it doesn't make too much of a difference. So that is quite good that you don't have to bother about. That is the biceps over there. This is the one that I tend to use where you can adjust your length by and add the final screws over there. So you can see, especially in a femur and a tibia, you want the exact length on that. And in the humerus, you have to be very careful that you don't have dislocations because the glenoid is very small. And these holes are for the muscles to be reattached, and that is the radial head over there. That is the post-op X-ray of the thing. There is a little subluxation. We're most concerned that superior subluxation. We tend to put stitches through these holes over here into the top because the commonest thing is to get a dislocation and inferior. Abduction in the humerus, you get very good movement if you do it in the elbow, the wrist, the metacarpal, the pelvis, the hip, the knee and all that. But the humerus, you don't get very good movement. Very few patients, about 10 to 15 can get about 40, 45, 50. And I had one patient get 85. But the majority of them will get no movement. They will have just about scapulothoracic. That's a femur patient with an X-ray. I'm not sure if you can see on the scan, that is the soft tissue mass there. We did a angio also to see. This is another patient with a diaphyseal femur tumor with this thing. It was a large soft tissue. It was not completely circumferential. It was mainly involving that, so we cut that. We don't get this very often in this thing, but in one way it is all right because you don't have to replace a joint with the prosthesis. Now here we use two halves of the prosthesis. I just go forward and backward. That's the two halves of the prosthesis put together. So here we cement each one separately. It's got an anterior half and a posterior half, and you have two screw holes for that. This is the knob for it to sit very nicely. This is because you cannot put cement and push it through the proximal fragment and the distal fragment. The length will not be the same. The vessel will be involved in that. So you cement one and then you cement the other, then you bring it together and put your screws on that. That is just with the cementing in and the screws. You see, this was just trialing it out without any cement over there. This is after the cement has been all put in and you tighten the screws. This again is in Indian prosthesis. I tend to use about 70% Indian prosthesis because we all know the prognosis of sarcoma and EWING'S sarcoma is not very good. We tell them that the foreign ones will last 25 years, but the Indian ones, I always tell them I have no idea how long it lasts. But you need chemo and this thing, and you don't know when you will get lung mets. There's whatever the percentage of survival is about 5 years, survival is about 60, 65. So in Indian is fine enough from my point of view. Definitely the quality of the prosthesis is not that good, but I think in our country we have to take note of what the financial constraints of the patients are. That is after the whole prosthesis. Now, I won't go very much over our standard mega prosthesis, the femur and tibia, because that is the regular thing. This is a tibial prosthesis. And here we have a problem that you have the ligament, the patella there, and the ligamentum patellae. And this all was osteosarcoma, so you don't know. Yeah, sorry, Ewing's sarcoma, and you have taken that out. So what I published in clinical orthopedics was to put a wire across. Usually in the West, they put them on they suture this with the gastroc, which I will show very soon. And then you will put them in a cast for about 6 weeks, or in the West, you put them on a brace because patients don't tend to remove the brace. In our country, if somebody removes the brace and the ligament ruptures off, then he will blame you, the surgeon. This is the wire, another lateral side view of it. These are all different patients, but I'm just trying to mix it up. I put these holes in these prostheses, and then that is the patella, the articular surface of the patella. That is the gastroc at the back. Usually the gastroc is used to cover this one, but that is mainly for the wound. The tibial wounds give us much more problem than the femoral wounds. So that is the gastroc, which you can see there. And we have brought in, this is a different patient. This is a link prosthesis, which is about 5 lakhs on cost. But it's a good one. It's a German one. And so we bring that because this tibial one, the wounds at this place, you will directly have bone, cement, and metal. And these wounds, if they break down, then it becomes a real problem. Usually here you have the muscle and everything that's a quadriceps muscle that you can see there. That is the polyethylene on the tibial one, and that's a metal on the thing. That's a little bit of cement over there. I think this is the tibial cement over there. So the gastroc I use mainly for this, but I use this metal wire which goes from that. That's the X-ray of that. So from day one, you can start the patient to bend. Now this is another X-ray of a different patient. I'm just showing that there's a long area where the diaphysis also was involved and the C was involved. Now this is another X-ray of a femur of a different patient. Here he had a very small bit of condyle. So this is another problem that we all face commonly as to what we do with this. When this patient was only about 37, and so I did not want to remove his complete condyle and put a prosthesis because this is an Indian one. So I devised a small little stem which is cemented in and then put 2 plates. This patient is about 4 years now, and you can see 1 screw is already broken, but he's walking well with that. And I had explained to him that whenever this thing, then we can do either we can see if this is all right, and then we have to first of all see that he's got no lung mets and all that. 4 years he has nothing, but we have seen recurrence sometimes in Ewing's sarcoma. I had a very unfortunate patient who got bad this thing at 11 years after. Now this is a patient who had a total femur, and this is the thing. It depends on whether if the intramedullary spread is very high, then the patient will have a very small segment of this, and then you will not be able to hold it. The other one is also an option. In this patient, we thought that it's so small that the intramedullary spread, so we had this. Now in the hip, we usually use a bipolar. The knee joint is a hinge joint, like I showed you earlier. And so the hip one is a bipolar. So that actually has 3-4 surfaces to move, like the usual bipolar. And therefore, the hip joint will last much longer than a knee joint. A knee joint will ultimately fail. We need to only, again, but the problem with the hip is dislocation is a problem. You can see a lot of vical sutures and some ethibond sutures and all that. We have to resuture the gluteus medius onto that. The abduction, this thing takes a long time for these patients. They all start walking, but they walk with a little Trendelenburg gait. Sometimes they are upset saying that, why are you after my gait? And after all, I am walking without crutches, and so that is fine. But it's good to keep getting that so that the patient walks on these. So that is the joint into the tibia also. This one is the quadriceps before we suture. That's another X-ray off the web of a total femur with an X-ray. Now, sometimes you use some other newer techniques on that. This is an Ewing's sarcoma this is actually a medical student from Kyrgyzstan, but she's an Indian and a Tamilian from here. And she had a large osteosarcoma there. This is the soft tissue component of Ewing's sarcoma melts very well with the chemo. but the bone does not make much of a difference, and the prognosis unfortunately does not make much. So here I decided to take off part of it and use computer navigation. And she had a different lesion there, which we needed to put in with the navigation and then put cement into that. And this is post-op, you can see that, I mean, post-chemo, it was quite interesting. So you see, this is, I used the striker one. It's quite difficult to get this, but I wanted to remove whatever was in the original inflamed area. The pre-op MRI was even much larger than this. And you always remove this amount of bone which was there in the, but whenever you do a pelvis, the pubic ramus, which sometimes can be very large tumors, about nearly 3 to 4 inches long, but that is a good one of it. The ileum is again a good one. The acetabulum is a problem, which I will come to very soon. So this girl luckily had, she had a very good necrosis also, nearly about 90% necrosis. So that is the navigation. You have to do a CT scan. You have to feed it into the navigation machine. And then when you actually do those things, then you have these navigation, this thing like you do the TKR one, and you feed it into that, which will register it. And those are the knobs, which are the usual striker knobs for. And with that, you have a striker. The striker has only a little thin one, which they are not able to attach it onto the saw and the drill. So this is their sort of equivalent of that. So this thing must remain on the iliac crest right through the surgery. That is her post-op X-ray, and she's only about 1 3/4 years, but she is doing well at the moment. I have removed that much of bone, and they have put a little bit of cement into that hole which was there. And I kept her non-weight bearing for about 6 weeks, and after that she has been walking. Now, coming to another recent thing about custom-made processes. So sometimes this is the usual MRI in an EWING'S where the intramedullary spread is very long. If you look at that X-ray, it looks as though it's only there, but this is from the net, and there's a soft tissue. That's a nice reconstruction of the tumor there, and they plan to remove that much. So then there's a very small bit here. So these are 3D printed, porous coated. They call it ultra critical defect, which is very small. And then you have screws also going into this. This is a foreign one. So as you can see it, this is published. This is a Chinese one, which is published in the Cancer Management. But it is quite good to that. Going back to the other thing, whether you could cut here, this is another very great question that we always have, as to whether this is tumor or whether this is periosteal reaction, like the same thing like the Codman's triangle, when it gets lifted on that. There we've been doing a lot of studies on whether to correlate the MRI-wise and the pathology, because you don't want to see that after you resected, the tumor comes back as positive, the margin is positive, because then you have to either do resurgery, especially if you've cemented, that's really difficult, or whether I would have probably preferred to save so much of bone, especially in EWING'S, because the children are much younger than anyway. So this is the custom-made 3D printed one. I think this is the way the world is going, where we will 3D print our tumor models, and when we will see. Distally, there are about 2 screws here, and which are holding it, but these porous coated implants are very good, and they really grow in this thing. Unfortunately, they are very costly. That is another person who came in with a nailing done. It was done somewhere else. They thought it's a benign lesion, and they did that. That is the X-ray which I showed you earlier. So that's the CT of that. Now these are some allografts. Allografts is being done for the last 30-35 years. There is a lot of argument. The allograft people believe that is the best thing to do. The prosthesis people believe this thing. If you go to Rizzoli Institute, there were earlier 2 people. And the allograft people believe in that, especially in children, you can use allografts, so especially in the diaphyses, you have to plate it. The whole question is how much of infection and non-union do you get? And in Italy, Rizzoli, the 2 groups, one person believed that it was very high and the other person believed it was very low. when I trained in Adelaide, my boss had trained in Seattle and he was very against it. He said he saw a lot of complications. Queensland, you should do a little bit of allografts. I myself have done very few, other than the the usual femoral head that we add into this thing. Other than that, allografts as such. I'm just getting some things off the net, a reverse shoulder or a longer thing, and some growing prosthesis, which I'll come down to in a little more time. The growing prosthesis, there are two types of prosthesis. One is the semi-invasive, where you open it and turn it every 6 months, and the other one is the one which is electromagnetically done by putting it through a machine. This is the regular. This is the regular one. This is made in Chennai. This thing. So this is, you have to make a small little nick over that every 6 months or so. It's very difficult in India to get these patients back. As long as the patient is 13, 14, 15, it is all right to do it, because they end up with about 2, 3, 4, and I find most of them are happier with the heel raise rather than come back for surgery. But one thing we must say, that now these are all titanium, but still in Indian prosthesis, but the cost difference is very, very significant, and that's the main thing. This is the electromagnetic coil. This is nearly 20 lakhs of thing. So I have put only one of these, and but it has a coil which will more ratchet. This is the semi-invasive one with a turning mechanism on that. So the Indian ones that we do this thing, but we did go through and the ordinary Indian one learning, and they used to break and this thing, and I think the AIMS, Dr. Shalam also had the same experience. Luckily, we were doing very few of them, and then we could revise them into a non. Now this is another growing one. This is something which have been operated elsewhere, and it has started. This is the knee joint which was there has started going into that, and it came out of the femur. And this patient came to me after about 6 to 7 years. And so this is a Stanmore one, which was very costly. Unfortunately, I could not get anything else. The link people were not making it. This I put in about 8 years ago. And all these link and the Stanmore ones and the GMRS ones have a small little hydroxyapatite coat here. So that will have bony ingrowth here. And then you put a cemented stem there. And but this cost nearly 16, 17 lakhs because I was no other choice, and Stanmore was the only one. The link was going through some phases of change, and now the link makes it. This patient is now 11 years post the first surgery, and he does not want it lengthened because it's again a semi-invasive one, and that is their mechanism. And so he has not, anyway, at this time. Now the pelvic tumors are a little more common in EWING'S more than osteo. Pelvic tumors is our big problem. Unfortunately, we tend to see them. Unfortunately, I tend to see them more often. That's an MRI of the same patient, and this is an Indian process which I put about 9 years ago. I haven't had from him, but as you can see, you just have to decide where you want to cut and decide. And here I had my length calculations had gone wrong, so I just cemented the whole thing. Anyway, you're going to cement it, but I kept it out of it. There's one screw into this. Here I could not put any screws, but I had a lot of screws over there. That is another patient with a talus Ewing sarcoma going on to the calcaneum also over there. He is a medical student, and his father is a general surgeon, his mother is a pediatrician. So we had chemo. He had actually about 6 or 7 chemos pre-op. And we got a link one to design it. This designing with the link people is very slow. The Germans are very sticklers for rules. And so now this one is a cemented prosthesis, so that is not a problem. This is about 12 lakhs. And they have screws which go into this. And he had post-op. He's about 1 year, 9 months now post-op. So he's doing well as of now. He's very heavy and tall, and so I've kept him non-weight bearing for quite some time, and then started on partial weight bearing, and now he's full weight bearing. I'm quite happy that Corona came because his medical studies were interrupted and he is waiting for them to restart his medical studies. That is his post-op X-rays. It's a little oblique. So the cemented portion is not worried. This is the screws, and this is where the grip is seen. As of now, it has done well. And then we'll see. Here, one of the problems that we find in the talus and calcaneum is that you don't have a grip, as I already said, but even this prosthesis, one of the problems which I find with the Germans are that they make it for the German size of tibia, which is or talus, which is unfortunately a lot like our Indian size. Luckily, this boy was tall, and so you have to keep telling them it has to be thinner and all that. But their metallurgy is very good. So they have just a small little hinge there. That's a hinge which goes in, and that's good enough to hold it. Their metallurgy is really good. When you use it, you really see and know that it is really very good. As you can see, I have put in the screws into a little bit of the next joint, but not very far. I didn't want to go further up, but he's all right now. Sometimes, if you get another diaphyseal lesion with this, and there is, this is an old X-ray of about 10 years old. We take it out and we put 2 fibulas in. I will show you the next slides. And this is an old one, which is he had a biopsy done outside and he got infected. And when he came here, it was infected. And so I was very hesitant to do that. But we gave him radiation post-op and we gave him chemo also post-op. So this is what we used to do earlier. Luckily, I didn't do this because giving chemo and radiation post-op to these patients are fraught with danger. The bone is very thin there, and I don't advise this now, but that this specific patient has this thing. We just cut off a little bit of that, and I was very careful to keep the nerve intact, and so he was fine. He has put on a little bit weight. Anyway, that's his post-op X-ray. That's his really one. But I had shifted some skin itself to cover the medial wound and then put an STLG. I'm just going to show some more pelvis because pelvis is our real bugbear, which we don't know what to do, and getting margins is very difficult. Prognosis is poor. These are just off the net, some prostheses which are, that's my, sorry, that is my ankle X-ray on this thing. I'm sorry, I just mixed it up, this one, but that is intra-op, the surgery you're putting it in. This is again off the net. This is allograft. As you can see with this allograft, you put this, the whole pelvis is an allograft which has come in from cadaver, and then you have screws put in all over, and definitely the infection rates can be very high in this. That is even an allograft where you put a long plate and you put a total hip and all that. So pelvis is poorer prognosis, major complications. It's just that amputation is easier, but again, we get into the limb salvage, this thing. The recurrence rates are also very high. This is a different type of prosthesis where you have wires going through this, and these are all have hydroxylotide, which get into regrowth, and that is very much better for younger patients because you've got a lot of bone left even when you need to revise. Now, complications are very severe in any prosthesis or any tumor surgery. Bleeding is there, infection is the thing, especially in tibia infection. Wound necrosis is very common. Again, more common in tibia. Local recurrence are there. I think the local recurrence is what is the main thing that the surgeon has to avoid. And we still have about 10-15% who either unmarried girls or this thing, and they say, no, sir, we are ready to take the recurrence, but keep the limb. And I still feel all my patients, they don't understand that life is more important than limb, and amputation is probably better. So amputation, if it is done primarily or sometimes secondarily, when there is some major complications, especially in the tibia, implant breakage, especially if we use Indian ones, aseptic loosening, bush change is the polyethylene that you have to change for the surgeon. For the patient, he is saying, sir, it's anyway an operation. Radiation complications are there. Wound necrosis can occur, can be quite severe. The MDT approach is very necessary. Neoadjuvant chemotherapy is this thing. You should not prolong the interval between chemo and surgery very much. Radiation, if indicated, quite often I tend to give it. The role of radiation in Ewing's sarcoma has swung back and forth and changed every 5 years. It's usually the MDT that we just decide on. In summary, it's a rare but common tumor. In our country, we see the infection and lymphoma are the main one, but the lymphoma part is the infection part is what is to be mainly diagnosed by the orthopedic surgeon. There are large soft tissue masses which pre-op chemo takes good care of. 75 to 80% is one report. Most reports are talking about 60 to 65%. And that is the non-Ewing's sarcoma. Thank you. Thank you very much for all of you giving me a patient hearing, and we'll have the cases now. Dr. Arnab?
Yes, sir. Thank you so much for the beautiful talk. So I'll request to the senior panelists present there. So you have to have few comments, or if anybody has any question. Kausikda?
Sir, I have a question for you, sir.
Yes. Yes, go ahead.
Sir, my voice is audible, sir?
Yeah, you are audible, Kaushik.
Sir, at your institute in CMC patients, what practice do you do for
Can
staging?
you talk a little louder?
Sir, at CMC VELLORE for Ewing's sarcoma, staging a biopsy or a PET scan?
For the investigation, I will always do a biopsy first because we need to know whether it is
For staging purposes.
For staging purposes. For staging purposes, yes, you need both. Ideally, in the ideal world, I personally tend to use PET scan less because the biopsy will tell you the diagnosis and it will tell you the grade. If it's low grade, which is not very rare in Ewing's sarcoma, then this thing. But I think in your place in Calcutta, you will probably tend to use PET scan more. But here we tend to this thing because the cost of everything else, 3 chemos, pre-op, surgery, surgical wound to heal, then post-op. So they have anything between 9 to 15 months to spend in VELLORE. Of course, they can go for a short time and come. So we tend to not do PET scan very much. I'll agree with you that we always do bone scan and we always do HRCT at some stage. At least one HRCT we do, usually before the first chemo. We don't tend to do HRCTs regularly because we have decided that we are going to give chemo and then we're going to do prosthesis. So in that, I don't think we get that many PET scan. It's a large amount of money for us. That is the main. But it is in the ideal world, yes, you should do a PET scan. It's good to do
bone marrow biopsy. Bone marrow biopsy.
Bone marrow biopsy. My chemotherapists and pathologists are also of the view that it is not of much use. But the old teaching was always, and we still go by it. Unlike osteosarcoma, which is a primary disease, we use the term in Ewing's sarcoma that this is a systemic disease. But so if we diagnose metastasis on diagnosis, then very rarely we offer surgery. We do chemo and radiation. But if there is no metastasis at diagnosis, then we give chemo and then we do surgery. So the bone marrow is not done in our institution as a routine staging, but some people tend to use it.
Any question from Jain Pal, sir? So what is the average life of this Indian prosthesis, mega prosthesis?
Now you are asking political question. Make in India is the talk these days, so I should not say anything. Yeah, no, the Indian prosthesis, I sort of was hinting at that it is not good. Okay. But the other view which I always have is the patient has got Ewing's sarcoma. We have no idea how many of them are going to get lung metastasis in the first 6 months or 1 year. Most of them come in the first 6 months or 1 year. After that, it becomes lesser and lesser. And after 3 years, we see very few. After 5 years, we see very few. And I've seen only one at 8 years and one at 11 years. And so I would tell them, instead of selling their whole house and everything and then finding that their child has lung mets after 1.5 years, it is better to put in Indian. And if the Indian one breaks, then we revise it and go and do something else. If that lung, that time again, we must do a lung CT, we must do a bone scan, and if it is there, then we'll see. But the Indian one is not good. But we have learned over the years, we've been using them for about 25 years. I must always say that Dr. Mile is the one who started it.
Yes.
And started using it. And this thing, I'm also using the Indian one, which I just showed the photo, that is Mile's person who makes it. And for our situation and our financial resources of patient, I think the Indian is the better. But we tell everyone that the other one is there, because the Indian processes cost about 1 lakh or 1,20,000, and the foreign one costs about 5 lakh. Now, I'm not talking of the custom-made ones. The custom-made ones are much costlier, but the standard. So that's a lot of cost difference, and that is the about it.
Professor A.K. Pal sir is there. Sir is one of the pioneer designer of total elbow prosthesis with DP Bakshi sir. He has designed it. So your say on that, sir, on prosthesis?
I unfortunately have designed most of my prostheses myself, because that time the person who used to make Dr. Mile's prosthesis, who now makes it, was one of the ones which I think he was very costly. So I was using a different person who used to make plates and all, who was making for Sri Ramchandra Institute also. There was one HOD there who was a little bit interested, a senior person who used to do a little bit of that. So I think it should be user friendly.
Yes.
And
yes.
Unfortunately, that person does not have FDA, so I don't use his thing anymore. Now I'm using different prostheses. But I think the Indian prostheses, a person must know which of them are, how to overcome it. I think the initial stage, we were all using very little of them, because we had to learn where it breaks and all things. I think the Ajay Puri from Tata published a paper on where exactly it breaks, because they had so many of those. And then this is of course the stainless steel era, before the titanium came in. With titanium, things have got better, but still you must know which ones break and which ones don't break. But definitely, sir is also a great he started designing it long before even Dr. Mile started. So that is a good one. I think you have to conform to this. One of the problems which I find with the custom-made link every time is they once gave me a distal tibia prosthesis, and the diameter to put into the tibia was 14 mm. And now in Germany, 14 mm is probably already a standard, but in India it is not. And luckily it was a tall person from Bangladesh, and it was a man. So I reamed and now it's about 6 years post-op. So he's doing well. But
so congratulations, sir, for your informative and very enriched talk. And we'll look after for these processes, which is really user friendly. Just I want to know, please give some advice. I have already used that mega prosthesis for the GCT, lower end of femur, but what you observed after 4 or 5 years, there is some loosening at the junctions. So what are the precautions to be taken paraoperatively as also post-operatively to increase the longevity of the prosthesis, this type of mega prosthesis? Can you please enlighten?
Stress. Yeah.
There is loosening in the junction between the prosthesis and the bone.
Yeah.
Okay. So then you will have to, this is something which is going to come, come again and again, and lots. It's going to become a big job for Dr. Kaushik and me and Dr. Jyoti and everybody, because there will be a lot of people. Obviously, these people will have survived that first 1.5, 2.5 years, and they will not get lung mets. And after that, so you have to decide whether the implant is going to break or not. And if the implant is going to break or the implant is going to break the bone, then it needs to be revised. And unfortunately, most of these people do not have the money at that stage to see. If it is a malignant one, I have been revising, especially my own Indian ones, when I was doing stainless steel ones, I was revising quite a large number of them. Nearly one revision a month I was doing, or 1.5 months. Because the stainless steel used to break, which included giant cell tumor also. But the other ones also. And unfortunately, sometimes we, very rarely, but we had to offer them only amputation. That is quite common in other places also, because this thing. But it is better to, and I was showing that other X-ray that when you can put a smaller stem, then that is always better, and that's why that condyle sparing surgery that we were trying. So ultimately, it is whether this, because if the bone also breaks, then you have to replace that, and then you have to do a total femur. We have to have the thing, and unfortunately, my earlier person doesn't have FDA approval, so now we have to only do the Adler, which is itself quite costly. But there's going to be many more patients like this. But if you can put a longer one, removing cement is not easy. I think all these revision surgeries take nothing less than 6 hours. By the time you remake, the drilling and the reaming can come out of the femur. Then when you push the cement in, that comes out of the femur, and then you need a sufficient length of bone. Especially if it's in the ankle, then it's a real thing. Revisions are a problem. Unfortunately, it is. So some of us think of retiring early or not, whether to do thing, because all our revisions are coming back. So that luckily, I think we have just, I hope so, touch wood, that we have a lot of wood in the brain also, that we have probably got over our stainless steel breakage patients. I'm talking of the Chennai ones, and so now we are in the titanium era, which is better, but ultimately they will all loosen out. But one thing which is good and bad is that they are then a cancer survivor, so you can't chase them away. With a broken implant or a broken bone, you have to do something. But unfortunately, it will cost money, and again we go through that and tell them that it's better to you to do a foreign one, but then, and the other problem with this foreign one is they insist on revising both ends. And especially with a joint, when you find the tibia is all right, why do you want to revise it? But the foreign people refuse to custom make it for that. Yeah, it is a problem. Revisions.
Any advices to increase the longevity, post-operative special advices?
To increase the longevity, I think you need to have a longer stem, but if you need to revise it, we all put the stem of 10 centimeters, and there is no basis for this. 20 years ago, I used to break my head, and I asked Dr. Mail and others, what is the reason for this? I asked Ajay Puri there, and nobody had any idea. The link people in their literature had advised 13 and 16 and even 18 in the old literature. I don't know what it now says. So one is to put a longer stem. But the thing is, if you want to revise it, then you have to put even a longer stem or a total. Okay. So there is no magic once it starts loosening out. Once it starts loosening, it's only a question of whether the bone will break or you have to revise it.
What is your antibiotic protocol?
We give 1 dose pre-op. We generally give 2 days of IV antibiotics. In any large institution, we get a lot more of infections. I tend to watch the wound myself at least by 3rd, 4th day. We don't have much problem with the wound because initially IV is given. If the wound is very clean, then we switch to oral. We give just a single small oral antibiotic for about 10 or 15 days. And after that, but infection is a real bugbear for us, and that is a disaster. If the infection is very rare and nearly doesn't exist. I've seen only one in the humerus. Everyone says there's never in the humerus. Proximal femur also infection is very rare. Distal femur, I have got away with a few. I have had to do 1 amputation. Most of the time the patient comes and says, I don't have any money for antibiotics. I don't have any money for anything. tibia is our big bugbear. And tibia, this thing, we are tending to do a little more and more, where you take out all the implants and put in cement spacers, and then you will have to revise it 6 months, 1 year down the line, and put in something else. Yeah, but because you've got so much of metal and so much of cement, once you get an infection and a deep infection, then you are really, especially if it's a tibia, your chances of success are getting lesser and lesser.
Okay. So another is, do you advise the bone hardening medicines like the zoledronic acid or teriparatide along with this, this operation in post-operative period?
Can you speak a little louder?
Do you advise the bone hardening medicines like the teriparatide or zoledronic acids after operation?
No, I don't advise it, because the metal, once it starts loosening out, it's also a question of whether there's aseptic loosening or septic loosening. And I am not very fond of IESR and CRP. It's a thing you can do, but anyway, once you think it is an infection, then you better hit it hard. The best thing for infection is to wash out early. That much is there. And you can decide on the table whether this thing, I'm slowly coming. Dr. Mile generally believes that if he gets infection early in a month or two, he immediately pulls the process out and gives it to the patient. I think now I'm also slowly veering to that point of view, because especially in tibias, because it becomes difficult to that. But back to your question, I don't think zoledronic acid and other things are going to change, because the metal is so heavy and the cement is so much that that is not going to take care of loosening. If the loosening is occurring, I think cementing techniques are very important. And even if I let my juniors do some of these things, I stand there when the cementing is there, unless I have 1 or 2 people who have done for a long time. And then that is very important to do it cementing well. And if you do cementing well, then generally the processes, breakage is really the problem with Indian processes, not loosening. Long term, we don't know. We still have not reached 15, 20, 25 years in any of our Indian processes, because that initial era was stainless steel. Titanium era has not gone. Zoledronic, I don't think it's a very useful. Neither world literature says it's of much use.
Rajiv, can I ask one question?
Sure.
Rajiv?
Yes, sir. Yes.
Oh, what is your experience, sir, in particularly diaphyseal lesion, and resecting that part and treating with high dose radiotherapy or cryotherapy, and then putting it back in position?
You mean taking the bone out and radiating and putting it in again?
Yes.
Yes.
Yeah.
Yes, sir.
I personally tried to get my radiotherapists to do that, so they were very against it, and therefore I don't tend to use that. I know Dr. Patro from JIPMER, who recently retired 2 years ago, was a great thing. I've been examiner in his institute twice, and so I've seen his machine and all that. Tata also tends to use it. For me, diaphyseal defects are not the problem, but it is less common. It is the joint, the hip joint and the knee joint, which is the problem, because that one you have to put a hinge joint and then that will wear out and all that. Diaphyseal defect is, you can, like I showed in my this thing, you can cement it in, and if it loosens out after some years, you can put a longer diaphyseal one, and then if that loosens out, you can take out the joint. So I personally prefer to take the whole bone out and put it with even an Indian process. And diaphyseal, that stem is going well into it, so there is not much problem about revising that also, unless you're in the end, which I showed you one where I put that, and I prefer to put that with 2 plates and to do that. That is becoming more difficult to make, custom make in India, but it's easier to custom make in India than this. I don't tend to use radiotherapy, but partly because my radiotherapist will. We can ask Dr. Kaushik, what is your experience, Kaushik?
Except for diaphyseal lesions, if there are no contraindications for autograft like pathological fracture, generally prefer to do a biological reconstruction, as Professor Pal has discussed. extracorporeal radiated bone, or a cryotherapy treated auto-frozen bone, or a diaphyseal reconstructions.
Yeah, I think cryo and these things are standard. These things in being done. I personally don't tend to do it much. I tend to put in metal.
Dr. Garg is here. Anand, what is your experience with cryotherapy? Yeah. Please unmute Anand. Anand, unmute yourself.
I didn't have too much experience. We just started doing cryotherapy. I did one case of EWING'S sarcoma who had a 1 year follow-up, and still now there is no recurrence and patient have a good function. So I did the pedicle cryo of the humerus, and I saw this case 2 times in the meeting, one in the WBA clinical meeting and one in this meeting. So I think pedicle cryo in spite also as well as free cryo. Take the tumor outside and is very cheap, economical and more cost effective and more biological. So many studies they are published in literature also. So we can use in very small setup where we have to know no sophisticated instrument or gadgets are available. So it has good results. And many studies still in Japan, they are doing continuously the free bone, taking the bone and doing the cryotherapy and put it back. So they didn't think about the even pedicle also. They will do as a free bone substitution.
I think everyone, one good thing which if done can be done is to, in addition to putting cryo or putting an allograft, is to put a vascular fibula inside, because that vascular fibula tends to take care of most of the problems of both these things, infection and non-union. So that is the thing, but unfortunately the operating time is one big problem for the vascularized fibula. And the second, this one is that only very large centers will have the facilities for that. So if you're not putting a vascularized fibula, I think even in the world, most people either prefer one or the other, or some people do it, and nobody has come up with any sort of even putting his indications why when he chooses. And I've asked Ajay Puri also this, and saying, when do you choose this? What are the reasons when you say mega and all that? That I think they tend to do more of this cryo than the others. It is just that personally I prefer that when you can, the metaphyseal and the epiphyseal ones are a problem because you're putting in an Indian prosthesis. But the diaphyseal ones I don't think is a problem. This one I think is a better one to do. If you can put an allograft or put cryo and put a vascularized fibula inside, because that takes care of much of the problems of that. But there are, as I said, there are 2 problems.
Dr. Deepak Rachuri, sir, I have a question for you, sir. Dr. Deepak Rachuri, sir, sir had been doing a pioneering works in the field of orthopedic oncology in Calcutta since long time. So can you share some experience of early custom-made process? We still now get the follow-up patients.
Can you hear me? Can you hear me?
Yes, sir, you are audible, sir.
Fine. Now, the patients that we treat in my hospital, those are actually of the low income group. And they can't afford the foreign prosthesis. I have used only the Indian prosthesis. And for the last 5-6 years, I don't find any loosening or breakage till. Kaushik,
Yes, sir.
that is what you
So we
want.
can hear you.
What you wanted to know.
Sir, I wanted to know when you designed the processes from Calcutta Metallics and you started doing in your early days, what is your experience and the follow-up? What is the survival of the process you designed that time?
Actually, I have not done any design processes, but I do whatever available here now at present. And in our hospital, the mega process is being for the last 4-5 years.
Some
There are a
network
few
issues there.
questions in YouTube. I think can ask Kaushik now?
Yeah, please. Yeah.
So, sir, in your case, which you have shown the in wings of tibia, so there is a question that can we use a opposite-sided vascular fibular graft to bridge the gap in case of wings of tibia? Or if yes, then how much is the minimum required portion for the distal tibia has to be present for that thing?
Okay. In the case which I showed with plates, I have used there's a large segment gap, and so I have used the opposite tibia. And I always prefer to use two fibulas, one vascularized and one non-vascularized. This person was not vascularized, mainly due to financial constraints and time constraints. So using the tibia, I think in a child is all right because the bone will grow back. But in an adult, when you take a large amount of tibia, the chance of fracture is quite high because you will have young adults who will ultimately, after their 20, 30 and all, they will tend to fracture. And if you remove the fibula is probably the bone that is this thing. So you were talking about removing opposite side tibia and this thing. Yeah, I think when we were junior, we used to use a lot of tibial bone grafts, but now that has completely gone because of the small chance of fracture. So I prefer to use one fibula is put intramedullary and one fibula is outside. And so the one which is intramedullary is usually vascularized or the outside one is there. I prefer that. The fixation you can either put with screws or with plates. It's all a question of wound and breakage. Proximal tibia, you have a little more muscle, so you can use that a little better. And distal tibia, probably a screw is better. But the screw is not very good. If you can get 2 screws, then it is a thing. You will have to keep a cast for at least 3 to 6 weeks and then start mobilizing the knee. I usually keep them and get them to OPD and take a slab off and then get them to bend myself and then ultimately put a BK cast and send them home for about a month or 2. But all in the tibia, if it's diaphyseal, all options are there. You can use a vascularized fibula, non-vascular, you can use cryo, you can use prosthesis. You can in tibia, I generally prefer not to use the prosthesis because infection rates are quite high in the subcutaneous bone.
Okay, sir. So one last question is that how much is the functional recovery in the joints after putting this mega prosthesis, especially in knee and elbow you have shown?
The elbow recovery it all depends on how much muscle is there. So majority of them, 90-95% will get good movement. It's only the proximal humerus which does not have good movement. In the knee, we tell them not to bend more than 90 because especially if you're putting an Indian one, then it is not going to last for very long. And but otherwise walking, I tend to keep them on crutches for a little longer. I say you full weight bear, but you use crutches. For me, the knee extensor lag has to be overcome because in the early days, we used to have some people who, especially after the chemo, they fall and break the prosthesis, which is a worry for the thing. And once they are this thing, they all ultimately they themselves get back to full weight bearing and the range of movement is good. Function on all these except the proximal humerus is very good. And proximal humerus also, all you have to tell them is that you will not abduct. Other than that, you can eat, you can flex your elbow, you can do whatever you want. They get a lot of flexion and raising the arm rather than abduction and raising the arm.
Regarding
Jyoti, yes.
Yes, go ahead, Jyoti.
Dr. Jyoti.
Sir, regarding your case of the proximal humerus prosthesis, you have showed there is a superior dislocation of the prosthesis. So, what will be the reason for this one? Is it because of the strong rotator cuff or because of the deficiency in the inferior cage or that may sort of thing?
Usually in the humerus, you get inferior subluxation, inferior dislocation, or antero-posterior dislocation. So I tend to stitch it quite well. And the one which makes it superior go up is a deltoid, because the deltoid by itself, when it puts it, you see any stroke patient, the deltoid will be and you get a superior subluxation because the deltoid overacts. And it is quite rare to get superior. Usually you will get a little bit of, the fight is usually to see that it does not subluxate, because Post-op, many of these people, the humerus, they don't get movement, and so they don't keep the muscles strong. Most of the patients I operate, a large part of the muscle has to be removed, and so superior is very uncommon. That patient has got a superior subluxation. You have to watch out for dislocations and inferior subluxation, and that is the main. And mind you, many of these people are asymptomatic even if they're dissing. Only thing is they cannot use the elbow and arm very well, the wrist, because you basically to eat your food and all that, the shoulder joint must be stable. Otherwise, the shoulder joint moves, and as it moves, they get a very disconcerting feeling, and they don't tend to use the hand.
Okay, sir. And regarding one more question, sir, regarding ankle prosthesis, you used to go for the fibulectomy. In all the ankle prosthesis, you go for fibulectomy. What advantage you will get with fibulectomy? Any limb length discrepancy or?
You're quite correct. Length discrepancy is the thing. So if there is a ½ centimeter shortening in most of my tumors, that size of tumor is large, and you have to dissect the vessel off very carefully.
Yes,
and you are most worried that post-op there should be no pulse problem, because at that stage, especially if you've cemented your prosthesis, then you got worries in that. But the second major problem is the skin closure. The ankle is an area where there is not much skin. There's not much tissue. There is no muscle there, so you can't take out that muscle and keep it. So you got bone there. So, and when you use an Indian prosthesis, the quality of metal is not that good. If you keep thinning it, we had an era when I used to tell the people that you make it smaller and all that, and they tend to break. The other really bad problem that you get is if there's a small wound breakage also, and the implant is seen immediately, then you need a free flap. And if you don't, then you get this thing, and sometimes the patient goes home and comes back, and they come with a small wound, only about 1 or 1.5 centimeters. But the implant is directly seen on the medial side. And then there is no other way but to take out the implant and leave it for a year or so, and then think of redoing that implant.
Okay, sir.
But then you need a much smaller one, or this thing and this. So one of the other options in an ankle always is to do an ankle fusion. Ankle fusion was something that we used to do in many benign tumors 20 years ago and 15 years ago. Now we are tending to use this thing. I'm quite against using an Indian process on a benign tumor. But when it's an osteosarcoma or an Ewing's sarcoma, I think it is good to get them to have that function and start walking on their own feet, because you never know when lung mets is coming and all that. So it is this. Yeah. So those are one is for skin closure, and the other thing obviously is for the.
What is your rehab protocol, sir? When you start weight bearing, or how much you mobilize the limb cast or the talus processes or.
The talus, I never give. See, once you use a foreign process, then you don't have a problem with that. But any prosthesis, I don't give any slab. You start. Only thing is, I tell them that you move around in bed, but don't put weight on it. The talus prosthesis, I kept him on non-weight bearing for 3 months, and then started him on partial weight bearing, and then reached full weight bearing at 6 months, because he was very tall and hefty and very heavy. So I was very worried about the talus fixation.
Okay.
Okay, sir. Thank you so much for your excellent lecture and discussion. So next we'll start case presentation. So I'll request Dr. H.P. GIRI to start his presentation. Yes, sir. Please unmute yourself and start screen sharing.
Sir, we have in our panel radiologist Dr. Hirakura Chaudhary and Dr. Arif as an expert radiologist, and Deval as a pathologist. So your X-ray and the slides, they will explain, sir.
Giri sir, first open your PowerPoint.
Okay.
Then share your screen.
share.
Down you have a green arrow, share screen. Yes.
You can see now.
Yes.
Yeah, we can see now. Make it in presentation mode.
Presentation mode.
Right side down, you can click. It will be in presentation mode. Right. Just left to 50%. No, this one. A bit more right. Yeah, this one. Yeah, click, and it. Yeah, we can see now. Yeah.
You can see.
Yeah.
Okay.
Yes, we can also.
Let us start. Good evening,
Yes.
friends.
Yes.
Good evening, friends. You can hear me?
Yes, sir.
Yes, we can hear.
Okay.
You are audible.
My case is a case of GCT first metatarsal and medial cuneiform in a teenage girl, 19.5 years follow-up. In the left, this is the problem. 15 years old girl, swelling left foot, slow growing for 6 months, followed by mild pain for 3 months. Growing faster after some operations elsewhere, 2.5 months back. Probably curettage and biopsy. No fever at present. On examination, GC is average, mild pallor, swelling, skin inflamed, warm, tender, size about a TT ball, over first metatarsal and medial cuneiform area. Feel is variegated, tensistic to firm. Movement is restricted in the great toe. Vessels, nerve, gland not affected. This is the blood picture. Hemoglobin 10 gram, ESR 20. X-ray other side of the foot normal. X-ray chest is normal. This is the presenting X-ray. You can see the destruction of the first metatarsal as well as of the medial cuneiform. There is a bulge out on the medial side also. This X-ray was earlier, about 4 months back, and it has progressed so much to invade the whole metatarsal as well as the medial cuneiform. This is the left side, normal side X-ray, and X-ray chest is normal. Now clinical DD, bone cyst, ABC, GCT tendon cyst, GCT tumor bone, bony tumor, hemangioma, chronic osteomyelitis, tuberculous osteomyelitis. Now, she came with the biopsy report. This was done earlier. Features are suggested. First two, she got the pathology report from 2 labs. One GCT consistent with the ABC, another GCT of the bone. But considering the age, they excluded the GCT. Another GCT presumably tenosynovitis, tenosynovial origin. But literature, this is the literature. First one, it is by the radiological, it is disturbing. Okay, first literature, it suggests it is the radiological classification out of 876 patients, they found 50 GCT. But no mention about the age group, particularly teenager group. In the second, there is teenager group, 2 cases. one is in humerus, another is in tibia. A third who has reported one case, it is in adult. GCT tumor of first metatarsal, but it is in adult. And fourth, they have also suggested first metatarsal GCT. It is also in adult, 40 years old. And fifth one, they have huge review, over 31 years retrospective review. Out of total GCT cases, 135, the children affected 17. And third metatarsal 2, not first metatarsal, not cuneiform. This is the repeat. And they all have done curettes and bone grafting. Now, what to do now? What I will do? Literature is scanty, recurettes and bone grafting, excision and reconstruction. If so, how much of excision and what would be the method of reconstruction? However, I followed the basic principle of reconstruction, that is resection of tumor and meticulous cleaning plus reconstruction with pre-fibular graft. This is the pre-fibular graft. Spinal anesthesia was given, pre-fibular graft harvested first. Now dorsal incision on foot, macroscopic finding grayish red soft lobular mass arising from first metatarsal, also embedding medial cuneiform with extracompartmental extension. But there was a fine cleavage, whole mass with soft tissues removed through cleavage. Reconstruction done with 3 left fibular graft by opposite fibular graft by fusing navicular and first phalanx fixed with IMK wire. This is the X-ray. You can see the X-ray reconstruction. Okay, this is proximal phalanx. This is navicular. You can see. Post-op management, what I have done. Operation done on 13/1/95, about more than 25 years back. 25 years back. Removal of stitches after 10 days. Walking iron plaster done after 3 weeks. Removal of plaster done after 14 weeks. Walking non-weight bearing after 14 weeks. That is crutch walking. Walking partial weight bearing after 15 weeks. Walking full weight bearing after 11 months. After resection, the next pathology report, histopathological slide is like this. GCT tumor, grade 2. Both are telling that it is grade 2 GCT. This is after 4 months. There is some consolidation at the junctional points. Yes, this is after 5 months. This is after one year, 2 months. There is fine consolidation and working nicely. This total fusion is there. Yes, after 13 years, she came with some ache in the same great toe, with some swelling also. I am at what to do. I take the X-ray first. You can see there is a elevation in the graft. There is an elevation in the graft. After inquiry, it is found that she is climbing stairs repeatedly over 1 month due to her building construction. And after that, she developed this. I thought it is probably healing stress fracture. Okay. Healing stress fracture. MRI done, there is no recurrence of bone tumor. This is after 18 years. The thick callus is developed and the union is there is the marrow has intermedullary area is fine, clear. It is now clear that grafted fibula has taken all the vascularization and healing capacity. Some dorsal bending developed due to malformation. This is her clinical picture. Foot is like this. There is nice scar, slight wasting is there. The arch is almost normal. There is some depression. Yes, dorsal extension and plantar flexion almost normal. Toe are moving okay. Now discussion. Giant tumor. Giant cell tumor constitute 5% of all primary bone tumors. It is locally malignant and may recur. Commonly ends of mature long bones, 75 to 90% are affected. Short bones are not spared also. Skeletally immature bones are rarely affected. Only 5.7 to 7.5% average. Average age is 10.5 years. But incidence of local recurrence, invasion, and metastasis is high. First metatarsal GCT invading medial cuneiform is still rare. No literature guidance is available as to the management of such condition. It was written some about 7 years back. Conclusion. Medial metatarsal and medial cuneiform GCT, particularly of teenage age, is a rare bone tumor. Here it has invaded the adjacent bone. GCT should be ruled out in any osteolytic lesion of foot bone, even in teenager patients. Wide dissection and reconstruction with free fibular graft is a good option. Even after more than 19 years, no recurrence or metastasis. Even stress fracture or graft healed satisfactorily. Thank you.
Please stop sharing your screen, sir. Excellent case presentation.
Okay.
Thank you, sir, for your excellent case presentation and rigorous follow-up and documentation, sir. I will is our histopathologist in the panel to histopathology report regarding grading of the GCT and the clinical implications.
Okay. Let us show.
Devmallo is there.
May I show this?
Hello.
Hello.
Am I audible?
Yes,
Am I
you are audible. Devmallo, please go ahead.
Okay. The histopathologically, we do not grade the GCT basically. The giant cell tumor is a benign entity, and there is a separate entity known as the malignant giant cell tumor. It either comes de novo or there is a malignant transformation of a existing benign giant cell tumor. So there is no grading system on morphology, on histopathologically for the giant cell tumor. I do not know why the pathologist in here also, Calcutta also, I've seen so many reports. They used to give the diagnosis giant cell tumor grade 2. And basically they make this grading depending on the mitosis and Ki67 value. Actually, what happens in giant cell tumor, there are two components. One are the giant cells and second are the stromal cells. So the stromal cells, basically, they show the high number of mitosis, but these are basically actually the normal mitosis, not the atypical mitosis, the typical mitosis. So depending, and this mitosis does not prove anything of the any it does not indicate any malignant behavior at all. So there is no meaning of any gradation. So the giant cell tumor means a benign. So grade 1 means benign, grade 2 means intermediate, grade 3 means malignant. It's not like that. Giant cell tumor means it is entirely benign entity.
Sir, it is reported 25 years back. And
Okay.
at that time, it was the system, it was the customary, we are accustomed.
Okay, but sir, just one thing I just want to say that when the GCT in very old book also by Dr. Kinney and Dr. Usha Kinney, this book by A5 Fascicles, or any very old editions also, there is no any evidence of any morphological gradation of giant cell tumor. So giant cell tumor always, so there may be maybe the gradation in the radiology basis, but morphological gradation is it is not evidence based. Till in past time also, I am not saying anyway.
Anyway, it is the report of the pathologist, and it is not the report of the surgeon or radiologist.
My question is Dr. Giri, sir. Sir, excellent follow-up and function from the patient point of view. Sir, did you use any special kind of footwear for there is a
Yes, yes. For some years, 2 years, so far I can remember, 2 years I given her medial arch support.
Dr. Giri.
Excellent follow-up. Yeah, Deepak
Hi,
sir,
sir.
please.
Yes.
Giri, just a small
Giri,
question.
sir.
Why you are
Giant cell. Hello.
Hello.
Am I audible?
Yes, yes.
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 So giant cell tumor of the short bones is not common, but it do occur. And in this case, as you are reporting, this is the second time after the first operations, you have taken the patient under your care. So what happened? There is soft tissue expansion, and as well as two bones are involved. One is the metatarsal, and another is the first kidney bone. So this is termed as polycentric giant cell tumor. And depending on the duration, either it should be synchronous or metachronous. But after dissection, I have two important questions. One is why you fuse the MP joint, because MP joint is very important, and also the other joints are certainly important, but MP joint is particularly important for locomotions. That is number one, and that is the reason why you are the patient is facing some problem with the IP joint osteoarthrosis, and also talonavicular joint osteoarthrosis might develop. This is expected. And the other thing is, in case of fibular bone graft, it is well acceptable, and it is also published in many literatures. But I think it is the tricortical bone which have the potentiality for early incorporation and early incorporation by the body. So that can be preferred in the tricortical bone for the iliac crest instead of the fibula, which is cortical. So union and incorporation both are delayed in the fibular bone graft. These are my observations and
First, taking of the graft, if you remember or recollect the taking of the graft, it is takes from the bridge. Okay, vascular tissue, vascularity from the bed. If you see my technique of fibular graft, I did drill hole in 90 long axis alternately, so that the vascularized tissue can go inside. Another point of choosing fibula, that it is a hard cortical bone. It will take the weight in future, so that it will not break. But iliac crest will not do. I think so much of iliac crest will not do, and the straight line will not be followed. There will be no straight line. This is the reason.
Actually, I am not contradicting you. Actually, what I am saying, that is another alternate method. I use it.
It is easy to take. Even it is easy to take. She was, another point is, she was teenager. She was teenager at that time.
I'm sad.
Only 15 years old.
Am I audible?
Yes.
First of all, why you have taken fibula from the contralateral? Number one. Number two, that, okay, first this question, why from contralateral?
Not contralateral, from the same side. From the same side.
Okay. Hello. Hello.
Yes.
Can you explain and discuss the picture of the slide? Where is giant cells, etc. If we open the slide, can you explain it?
Hello. Am I audible to you?
Yes, yes.
Okay. I have one comment here. First case, that was the guest lecture, that was very fine. And the case presentation is also very fine. It's parallelly equal. I can quote one thing. Dr. GIRI, that he has presented this case, and in his institution, his teacher, Dr. Professor Hemendev and Dr. Anil Chaudhuri, they presented a case in the West Bengal Orthopedic Association and published in the IMA JIMA journal. And they did it with another metatarsal. Probably it was the fourth metatarsal they took it. At that meeting, at that time I was a registered NRS Medical College. And I proposed whether the fibula can be taken or not. And the fibula, the benefit, particularly in the younger generation, the fibula takes it well. And Professor S.S. Jadhav mentioned it very nicely, the wonder bone fibula. And it takes very nicely. And again, the gap which is made in the fibula, that is also repaired in children because the periosteum is very highly vascular. I must congratulate for the excellent work. And the long follow-up he has done and managed it very nicely. He deserves a clap. Thank you.
Thank you, Topanda. Okay, this is the slide. Can you see that slide?
Deep Malo is there?
Hello. Hello. Hello.
Hello.
Hi, am I audible, sir?
Yes.
Yes, yes.
Oh, sir, basically these images shows the two population of cells that just I described previously. There's one of the giant cells. See, the giant cells can have the up to the 200 nucleus. So usually we used to get the giant cells with the 40 to 50 nucleus. Basically, the giant cells, they appears from the by just fusion of the stromal cells, because there's a very nice nucleus similarity with the stromal cells and giant cells. And apart from the giant cell, there is the round to oval stromal cells are there. Two things we should keep in mind, that the mitosis can be, the typical mitosis can be seen in the stromal cells. Sometimes the giant cell tumor has a very high mitotic index, but no atypical mitosis should be there. and nuclear epithelium should not be there. Another thing is that the giant cells should not show any kind of mitosis, typical or atypical, and they should not show any nuclear epithelium. Okay, so here you are getting that giant cells, which are the multiple nucleus. They are osteoclastic giant cell, and there are lots of stromal cells are there, which are round to oval in shape.
Okay, thank you.
Thank you. So I think we can move to the next case. Yes. Yes, sir. Yes, sir. Yes, sir.
Yes, sir.
Okay, may I stop sharing?
Yeah, please
Yes,
stop
yes,
sharing.
yes.
Regarding opinion about the staging and grading, actually, in the day published during 70s, it was there. Staging, radiology was staging by the NAK 1, 3, and pathological grading on the character of the stromal cells. It was the Jaffe. It was 1, 3. It was there. And all the pathologists during that period reported whether they want grade 2 or grade 3. Not that it was not there. We changed, it was changed, or it was changed. What is this continuity? Naturally, it was there.
Okay, sir. Thank you. So request
Next
Dr.
case.
Jyoti Prakash to quickly show his case because we have 10 minutes left. So we'll do another case.
Please involve Dr. Arif for your radiology part.
Sure, I'm ready. Good evening, everyone. So I'm the last batsman. Quickly starting my case. Patient is 28-year-old male, Hindu, blue collar worker by profession. Complain of pain and mild swelling around right knee joint for 3 months. Apart from this, he had no any considerable symptom, no history of trauma, no other significant past history of tuberculosis or any other medical history. Going for the protocol, I got an X-ray done, and I will ask Dr. Arif, please highlight upon the X-ray. Dr. Arif.
Sir, are you here?
Am I audible, sir?
Yes, sir. Please go ahead. You're audible.
Okay. So this is an X-ray of the knee joint showing mild changes, showing changes of the osteoarthritis as well, and we have long intermedullary lesion in the tibial epiphysis, in the proximal tibial epiphysis, extending into the metaphysis as well as in the diaphysis. I think the total extent of the tumor is not. This is basically intermedullary lesion, and total extent of the tumor is not visible on this X-ray. It might be extending further down. So as we can see, there is expansion of the bone without any destruction, and we have few septation within the lesion. So I think this looks like a benign sort of lesion.
Any else, another X-ray you want to know, you like to say, or we go for the...
We can proceed. This looks like a benign lesion.
Any comment from distal knee?
Okay.
Pardon?
I want to know from Arif, Dr. Arif about the distal knee joint. It is also seems to be eroded from things.
Knee joint is showing osteoarthritic changes, sir, with reduced joint space and osteophytes and all.
Okay.
Pal, sir, are you saying something?
Is there any evidence of calcification in the epiview?
Yes, there's septal calcification over there.
Yes,
Some amount of ground glass sort of calcification inside.
So
that actually goes into some low-growing intramedullary chondrosarcoma.
Yes, sir. So I will show the MRI. Dr. Hirak. Yes, the choices.
Sir, are you there?
Oh.
Hello. Okay, so we have this MRI, and the lesion is quite sharply defined, as I was mentioning in the on X-rays that it might be extending down. It is not the case here. So the lesion is sharply defined, and this is an expansile lesion. This is fat saturated T2 weighted images. So we have predominantly hyper intensity within the lesion, which represent mainly cystic component. There is no cortical destruction. There is no extension into the joint cavity. There is no periosseous soft tissue. There is no periosseous extension. We have some amount of hypointensity within the lesion at the posterior aspect that we need to further see if it is calcification or something else. So do we have some more images? Contrast.
These two images. T1, I mean, T1 image not available.
Okay, sir. So the margin and the margin of the lesion and the expansion of the lesion, I would suggest still that it looks more to me a benign sort of lesion.
Benign. So what are your DD, sir, at this point of the time?
I don't have all the MRI images. Based on the X-ray, I would be interested in fibrous dysplasia.
Okay, sir.
Yes, and it might be a bone cyst.
Okay, sir.
And these two are the differential for me right now.
These two are the differential. Okay, so with this background, as a protocol, we went for the corneal biopsy. Do you need, Dr. Kaushal, do you need PET scan for this thing? For this case, for the follow-up?
PET scan for diagnosis?
Pardon? No, for the further follow. As Dr. Arif told, he is at the video of the bone cyst of fibrous dysplasia in the benign lesion. So, do you want any investigation or further radiological follow-up?
When I think HRCT is also not necessary.
You are not audible. Unmute yourself.
Yeah. From clinical radiologically, it seems to be benign. Then I think chest X-ray is sufficient for this patient. Whether it is need the HRCT for workup and PET-CT, definitely I think not.
Okay.
Arif,
yes,
Arif,
sir.
yeah,
Yes, sir.
My question, Jyoti, can you please go back to MRI? Yeah, though the cross-sectional means axial cuts are not here, if I am not wrong, we can appreciate some secondary ABC-like changes, a horizontal fluid level. So can
Yes,
you
sir.
please show some guidance to which part, if at all you are planning for the needle biopsy, which part of the lesion you have to hit to get the maximum representative amount of tissue?
Sir, as you can see, the for this particular lesion, anteriorly we have all the cystic component, but we as you can see in the proximal part of the lesion and at the posterior aspect, we have some heterogeneous sort of signal intensity. So we can target those. Otherwise, it is very difficult to take a proper sample from this lesion. So can you, at the posterior aspect, can you see the some heterogeneous sort of? Yeah. We can target those. Otherwise, very difficult to take a biopsy.
Yes.
I have one question. I have one question from our senior faculty and our guest faculty. What is the reason of osteoarthritis? Arthritis is this patient. Is the tibial disease lead to the osteoarthritis of femoral component?
Osteoarthrosis may be of its own. So the patient was having osteoarthrosis and the tumor process started. That is probable.
Probably due to the
And
TB.
so in that case, if we take the bilateral X-ray, that will give the good answer.
Okay.
So because of the time, I will go for the cordial biopsy. Biopsy version, have the biology slide with us. Dr. Demalo Banerjee, please do the light.
There are two types of cells, and in that image, particularly you're getting there lots of the osteoclastic giant cells, which do not show any nuclear ATP or mitosis. And apart from these giant cells, there are the stromal cells also, which are round to oval in shape.
বলুন আমি ওই আপনি যখন আগে ফোন করছিলেন
And the stromal cells show some mitosis, but there's no definite nuclear ATP or atypical mitosis. So diagnosis is very straightforward. It's a giant cell tumor.
Giant cell tumor. So now we are differing on the radiology and the biopsy. Biopsy finding is leading towards the giant cell tumor. So what should be done? Dr. Anand Garg, what you want, how you want to proceed?
First, Jyoti, we didn't differ from the radiologist. They already told it is a benign sort of lesion.
We are the
GCTC also a benign sort of lesion. So I think it seems to be same. Next, before giving your answer, my question is again whether CECT is required for a thorax or PET CT still you want.
So I will ask this question. I'll put to the senior faculty what they say.
I think chest X-ray will be sufficient for this patient. What's the opinion of our senior guest faculty, Professor Titus?
Titus, sir.
Titus, sir. Hello.
Yeah. I think chest X-ray is enough. The main diagnosis is in the biopsy, and so chest X-ray should do.
Okay, sir.
And regarding question to you, what is the planning of the treatment? Regarding planning of treatment, as we all know, proper pre-op evaluation with the X-ray and as well as MRI whole length MRI, and after core needle biopsy, if you are sure it is a giant cell tumor, definitely first priority and maybe the last priority for all of us is extended curettage of the whole of the lesion, make a window, and reconstruction with the bone cement and with the fixation, I think. Plate fixation. That would be better.
So what will you Yeah, Professor Pal sir, as Dr. Garg told you should go the bone cementing, whether you would prefer cementing or the bone graft or sandwich technique?
No, actually extended curate would be my choice because that will allow early mobility and supporting, maybe added with sandwich bone graft, and then bone cementing, and that will help us to identify any recurrence if that, and also it has some heat production which can cause the remnant or retained.
I'm also of the same opinion with Professor Jiten Pal.
I have a question from Professor Titus regarding sandwich technique. Is it still they prefer doing sandwich technique or anything else?
I personally don't use sandwich much, but the principle is the same. You should not allow the cement to directly go onto the articular surface because it is very hot and it will burn and damage the articular surface. And a long time ago, we used to see these patients and we find that the articular surface is completely worn out and the cement is on the femur. So I would prefer to put graft there. layer so that there is no either a tricortical graft or multiple pieces of graft, and then cement there. If there is any doubt that this may path fracture, which I don't think is any doubt in this case, then you can augment that graft with a plate. But in this case, probably there is multiple pieces of bone graft at the top near the articular surface and then cement there. That should be.
Sir, what adjuvant do you use?
I would prefer to use all adjuvants. It is easier to use peroxide and distilled water because that is available. Also, I will use phenol and liquid nitrogen. Liquid nitrogen is available for us. It is only in large institutions that you have. But the main problem with this treatment is that there is a chance of recurrence, and therefore I would use everything in my armamentarium. It is not something which would take anything more than a few minutes to use that. I use a spray which is there, which the dermatologists can tend to get, and then spray that to see that the skin is not involved. So I will use all the 4 adjuvants.
Okay.
Any specific points or anything information you would like to share? In which cases you use H2S, to which cases you use phenol? Anything, some information?
I tend to use everything. There have been a few international studies trying to compare it, but the cases are so different that when you see them, it is not able to, you are not able to take any message out of that saying this adjuvant is better than that. I think the recurrence in GCT is high and you should use as many adjuvants as you can. And liquid nitrogen only is a little difficult to get, but phenol, peroxide and distilled water everyone can use. Even in small centers, it's not a problem.
Okay. Any experience with denosumab?
I have been using denosumab of late only, a little more. The problem with denosumab is the world literature does not know how long to give, when to stop, and I'm afraid it's a largely company-driven this one. And so therefore, if I think that the chance of recurrence is high, and I would say that this one I would normally like to do a prosthesis, but a case like that, but because number one, the patient is very young. Sometimes when the patient is a lady, especially an unmarried lady, and then you get pushed into the scene, you explain all the choices and then go for that. Those cases I tend to use denosumab a little bit more. I am using denosumab a little more. I've used twice in the last 5 weeks, but that is basically because those patients, I have a feeling I do not know when they will come back from far away. And so I've been advising them that. And I've been advising 3 to 6 months.
Professor Pan, sir, so your experience with denosumab in case of GCT?
Denosumab, if we decide for curators, then denosumab should not be used because that will cause a lot of difficulty in curating the material and tumor tissue may retain. So when a resection is in that case, preoperative denosumab can be given, like the lesions or somewhere. So in where curator is decided, denosumab should not be given. And regarding post-operative therapy, I actually routinely use 2 things. One is vitamin B, and another is bisphosphonate group of drug, alendronate or pamidronate we do not use because of the non-availability.
I was talking of using post-op denosumab, not pre-op denosumab. So I agree with sir that pre-op should not give. Post-op is yes or no.
Post-op, sir, how
হ্যাঁ বলুন। হ্যাঁ হ্যাঁ অপারেশন হবে, রিপোর্ট এসে গেছে নেগেটিভ।
Post-op, sir, what is the frequency or what is protocol for the post-op denosumab? In what frequency, in what dose, sir, do you give, sir?
Nobody knows, and the world is teaching, and in the Western countries where there is no financial problem, they do not know when to stop.
Okay.
And there are recurrences in that also. So there is not much. This thing, people are trying it out, and nobody has got a definite this thing. Nobody has suggested a regime of this thing. Different people have used different things. It is something quite, though it has been around for 15-20 years, there is no agreement or this thing on that, and nobody really can say that give so many doses post-op, even if you are this. I think if you, my view is if you think the recurrent chance is high, then you tend to give it. And I'm tend to use it more because earlier I used to tell my patients, if you see any swelling, you come running here, because if it is small, I can again do a joint salvage. But now I do not know what's in, so I'm in the last recent past, I'm tending to use it a little bit more.
Okay. So this was the management done by me. The extended fluid was done, bone cementing, and the proximal tibial lock plate was done. This is the immediate post-op, and this is the 6-month follow-up. Though the follow-up period is very less, still we need a longer time to conclude whether recurrence is there or not.
Recently, the people are suggesting for this kind of construct.
Dr. Jyoti, can unshare your screen so that we can discuss and conclude.
Sure.
Right. So, any comments on the management? Professor TITUS, sir?
Yeah, I think it's a good management, and it
probably right in that sense.
Only this thing is that I will probably put some monograph to the top, but that is fine. In his X-ray itself, I can see some bone on the medial side, which is there on top. On table only, he would have realized what this thing. If there is any bone which is left there, then you can put cement directly on that.
Okay, sir. Thank you. So, any faculty wants to add any comments? Otherwise, we can conclude with concluding remarks from our president, sir.
One comment just to keep the follow-up, because the X-ray is not classically looks like a GCT, first thing. Second thing, pain and gradually swelling. Usually GCT, we didn't find so much pain. So from clinical radiological, still we are not sure, though convincing is a benign lesion. So it is longer follow-up is really
changes.
Yeah, really required.
No, the cause of pain maybe the arthritis is what we see in the knee joint. It may not cause a tumor.
That's why I'm asking you, what is the reason of osteoarthritis in this patient?
Yeah.
Okay, nice case, pretty much.
Thank you.
Chinmay
So,
sir?
yes, sir. Sir, please conclude with your remarks. Chinmay sir.
First of all, thanks to Dr. TITUS for his nice presentation and high-tech surgery for management of EWING'S sarcoma. Actually, this kind of surgery is possible where money is not a problem and infrastructure support is there. But in our state, most of the medical college is outside metro, and this type of facility is not available. So we have compromised regarding treatment of the EWING'S sarcoma. And some comments about the technique about the bone graft. When the go for curator, then tumor has reached almost to the level of subarticular bone or articular cartilage. There we have to definitely, as Dr. TITUS has suggested, we have to put iliacus graft to save the articular cartilage and to save this bone, that is the grafted bone, from the heat effect of bone cement, we have to put some support, inert support, that is the gel foam. This is basically is called the sandwich technique. And demotional, I don't have any practical experience, but demotional theoretically, when you are planning for curettage, and the curettage, it needs some body support all around. Sometimes the tumor is so extended, and one side then deficient. So in that situation, we have got a demotional which form the bone cell all around. Then we should go for, or we can go for curettage. So this is almost all about the part of the genital tumor. Again, thank to TITUS for his nice presentation and theoretical update of the how far we can go for the management of sarcoma. Thank you all.
Thank you, sir. Thank you, sir,
Thank
for
you,
being
sir.
here. Yeah.
Thank you so much. Have a good night.
Happy career.
Okay, Tata.
Give you